Right, good evening, everybody. Thank you very much for giving up your time this evening. I'm delighted to have Mr. Parag Jaiswal going to do a talk on hip and knee imaging. So thank you, Parag. Without further ado, I'll introduce myself. So my name is Dr. Lizzie Tuckey. I am the managing director of scan.com, and this is part of a series of webinars that we run to support doctors, surgeons, physiotherapists, and general clinicians. So anybody that's interested in ordering imaging or interested in learning more about how to use imaging in the orthopedic pathways. Just to give you an idea of what we're going to cover tonight, ultimately we want an interactive session. So Parag is going to present some slides, but please do interrupt him in the side chat and ask questions, and we'll try and get them answered as and when we go. Hopefully you will end up understanding a little bit more about when to refer a patient for imaging by the end of the session. So what is scan.com? Who are we? Ultimately, our main goal is to improve medical outcomes by speeding up the time it takes to diagnose conditions. And we do that by enabling patients to access imaging more quickly. We've got an online marketplace, a bit like booking.com, where you can access any scanner in the UK pretty much. You can see what the price will be, and you can book in a slot online and have your scan done within 24 hours in some sites, but about 80% of our scans are done within 7 days and reported. And that really enables people to bypass waiting lists and to get access to scans if they want. The company was built by clinicians, so founded by a radiologist, consultant radiologist, and is run by clinicians. I'm a doctor myself, and we have lots of different clinicians working in the business. That's a little bit about scan.com. You can go on our website to find out more. And I wanted to introduce our speaker. So Parag's been a partner of ours for a while now, for about 3 years, supporting Scan, using scan.com for his imaging on his patients. But he is an consultant orthopedic surgeon with more than 20 years of experience. And I'm going to let him tell you a little bit more about himself. But we're delighted to have you here again, Parag.
Well, thank you, Lizzie, and welcome everyone. Thank you again for giving up your evening to hear me speak about hip and knee imaging. The title of my talk is Scan, Treat or Wait, and hopefully this will give you practical decision-making algorithm on when to refer, when to send for a scan, and when to sort of continue in rehab. So I'm Parag Jaiswal. I'm a consultant hip and knee surgeon. I was reasonably active on social media, but there is a lot of information on my website, on the conditions I treat, and also on Instagram. So I was one of the first academic clinical fellows appointed on the Stanmore rotation, and my training started in 2007. During this time, I wrote a thesis, an MD, on cartilage injuries in the knees, and this led to numerous prizes and publications. Following my training, I spent a year in Calgary, in Canada, in the Joint Reconstruction and Sports Injuries Unit, where I really honed in on the complex hip and knee problems and surgery for those. Following that, I returned as a fellow in Frimley Park Hospital, which is a military-based hospital where I treated a lot of young soldiers with hip and knee problems before they needed joint replacement. I was then a locum consultant in Guy's Hospital, which is where I trained as a medical student. So it was a lovely homecoming. I spent a couple of years there, and during that time, I was awarded the British Hip Society Traveling Fellowship, which led me to Vail, Colorado. Sadly, not during the winter months, so I didn't ski. This was in September, but really, I learned a tremendous amount from world-leading hip and knee surgeons. This all culminated in my permanent substantive post here at the Royal Free Hospital, where I lead the young adult hip unit and also do a lot of joint preservation work as well as hip and knee replacements. So why does this talk matter? I'm seeing a lot of patients with persistent problems in the hip and knee, particularly in NHS, but also interestingly in the private sector too. And whilst we might be sometimes too quick to scan, and that can lead to findings, incidental findings, and unnecessary anxiety, I think there's a certain amount of underscanning that occurs, which leads to not misdiagnosis necessarily, but also delay in the diagnoses. And ultimately, scanning at the right time after a period of some sort of treatment, be it physiotherapy, rehab, osteopathy, then ultimately scanning at the right time leads to the correct diagnosis, and instigation of the correct treatment and better outcomes. So I quite like the 3D framework when you're presented with a patient with a hip or knee problem, or in anything really. And the 3Ds are duration, deficit, and any danger signs. So duration, obviously, if it's acute, it's difficult to examine the knee, and this is when, or the hip, and this is when a period of some sort of standard RICE procedures, rest, elevation, ice, getting the acute swelling and pain down, and then reassessment would be good. Also, I see a lot of patients that have chronic pain, and they're still waiting to see an orthopedic specialist. A GP referred, I don't know, 2-3 months ago. They're still on a waiting list to be seen. And then the problem becomes chronic, and it's slowly affecting not only activity-related issues, but then start getting rest pain and night pain. And then I see a middle ground. So I see patients with an established diagnosis, such as arthritis or a degenerative medial meniscal tear, and they have an acute flare-up, either not necessarily trauma or injury, but just some sort of increased activity leads to worsening pain. That's an acute on chronic pain or a persistent pain. So the duration is important. And then the next D is deficit. So I see a lot of patients that have gone through the MSK pathway. So they've had some physiotherapy, they've had some improvement, but they haven't got back to where they want to be. And so I typically ask them, so what's this hip pain or knee pain stopping you from doing that you'd like to be able to do? And I have a couple of jokers that say, well, I'd like to run a marathon. And I ask them, well, when did you last run a marathon? And they say, never. So it has to be married into their previous baseline level of function. But that is important. The deficit is important. And any mechanical symptoms, that can be in the hip and the knee. We know the mechanical symptoms in the knee typically present as giving way, where they change direction and they suddenly fall, or they have a sharp pain and they fall. But you can get mechanical symptoms in the hip as well, with painful clicking, clunking, and the hip can give way. The other mechanical symptom to be wary of is locking, and you have to be very clear in what that means. True locking is when the patient has an inability to fully extend the knee, rather than some people think, oh, my knee locks and I can't bend it back. So that's what true locking is an extension deficit. And you can get painful clicking in the knee. That could be a result of a meniscal tear that's flapping in and out. The final D is danger. So look out for the danger signs, or the so-called red flags. And I'll go through what they look like and what you should look for. And those are definite signs for referral, not just for an MRI, but straight to potentially a specialist. Once you've determined what the Ds look like, and particularly if there is a significant deficit, if they're unable to weight bear, you then need to decide whether to wait and to continue with rehab, or to send for a scan, particularly if they've had a period of rehab and they have persistent symptoms, which is part of the duration, or to refer if they have any red flags. I've used this slide before in my hip talk, and this is, I think, is a really good slide that I've made. Basically, it determines your differential diagnosis based on the location of your hip pain. And 80% of hip pain is actually felt in the anterior groin, right in the front of the groin area. And the most common pathologies are arthritis, or FAI, or femoral acetabular impingement, with or without a labral tear, and also developmental dysplasia of the hip, which is a spectrum. And these quite often are quiescent. They don't really cause any symptoms until the labrum gets torn. One must also be wary. Those are the three most common, but you must also be wary of AVN, or avascular necrosis, or stress fracture, and then a rarer form, which in my practice I see quite a bit of in sports people, are your psoas issues. If the pain is located laterally, the most common cause is greater trochanteric pain syndrome, which is basically a condition that encompasses three main things. Trochanteric bursitis, and that can usually occur in 20-30% of the time with a gluteal tendinopathy. And then the final thing is external snapping of the hip when the iliotibial band rubs over the trochanter. Occasionally, piriformis syndrome, which is typically a buttock pain, can radiate to the lateral side. And the yellow ones are extra articular causes of pain in the perceived to be in the hip. So you can have pain, radicular pain, or radiation from a lumbar spine issue. Pain in the buttock can be typically in the sacroiliac region, as well as from the lumbar region. Posterior impingement signs are quite rare, and I won't go into that too much. But the younger age group is these three areas which I see a lot of. So some of the red flags or some of the questions to ask or be wary of, and I'm going to put this out. I'd like you to be active, and I don't know if someone's on the chat box, but I'd love to know, what are your thoughts? What do you think could be causing pain, which you need to be really worried about if it's continuous night pain that's disturbing their sleep?
You've got a question whilst you wait for people to respond to that.
Yeah.
Hi, Doc. How common is a hip flexor tendinopathy seen? And anyone else on the call, can you answer the questions on the slide?
So hip flexor origin is something that I'm always wary of. I see that a lot in my practice, where I'm a young adult hip specialist. I don't think it's that common in sort of a general orthopedic problem, because sometimes the hip flexor origin tendinopathy can mimic hip impingement. And there are certain strategies I do to try and elucidate exactly what the cause of the pain is. So before I embark on a hip arthroscopy, for example, to treat FAI, because quite often the two conditions can be together. So you can have an MRI suggesting hip impingement, but you can also have a hip flexor origin tendinopathy, particularly of the rectus femoris. So what I tend to do under those circumstances is a diagnostic injection of dye and steroids and local anesthetic into the joint with an EUA, an examination under sedation rather than anesthesia. And I take the hip through different ranges of motion to see where it's impinging and what kind of a pain response they get. Hope that answers your question. Do we have any answers for the first one?
We do. So is pain, what's the first question? Sorry, just remind me, because I've got so many answers.
Is pain preventing sleep at night? If yes, what are you worried about?
Stress fracture AVN from Jonathan Thomas.
AVN is a good shout, 100%.
A couple of those. Cancer related I've got, and I've
tumor
got
you've got to be wary of tumor. That can cause night pain. The tumor, the primary bone tumor, that's very typically associated with sleep disturbance and night pain, is an osteoid osteoma. I still remember that from my FRCS multiple choice question.
Yeah. So what else have we got? We've got stress fracture, rheumatoid arthritis.
So rheumatoid arthritis or inflammatory arthritis will typically present with morning pain and stiffness and difficulty to get going for about 30 or 40 minutes in the morning. So let me go through that. AVN, AVN, and then severe osteoarthritis. So remember I said initially arthritis will present with activity-related pain, and then typically when it gets more progressive, patients complain of pain at night because of the activities they do. Okay, the next one, unable to weight bear. Someone said stress fracture. Anything else?
ASPA? No, everyone's
AS,
saying, yeah, sorry, Leonie Greaves. I don't know. Could you spell out what ASPA is? Inflammatory arthritis, adverse reaction to medications, femoral neck shaft fracture,
yeah,
dislocation.
well, trauma would definitely lead to inability to weight bear. But again, I think the number one thing to be wary of is infection. So tumor will cause sleep disturbance and difficulty weight bearing, but that's variable. It depends on how big the tumor is and how invasive it is. But septic arthritis in the hip will almost undoubtedly lead to difficulty weight bearing and putting any weight on that leg, as well as a stress fracture. And again, this is also a spectrum. So whilst you need to be wary of difficulty weight bearing, there'll be some people that just are able to limp, and some people after about a couple of weeks are okay, but they're not able to run. So I've seen just literally today, because post-marathon season, patients complaining of an inability to run. They can still walk, but they can't run. And so rather than a fracture, it might be a stress response. And that would be an indication to certainly send for imaging MRI straight away, because there are some absolute nutters who will continue to run through the pain, and that stress response will lead to a stress fracture. So the two things to worry about are stress fracture and infection. Now, with infection, always there'll be some sort of other additional symptoms, such as general malaise, feeling unwell, sometimes the temperature. The hip joint's a deep structure, so you won't see any redness or swelling, but you certainly will do in the knee. Okay, history of trauma, we talked about fracture, but the other thing is, which I saw a lot of during COVID, and in fact I still see it now and then, is sometimes you can have an undisplaced acute fracture, and the patients limp and limp and limp, and then that leads or progresses to a non-union, and the leg becomes shortened. So I've seen a few of those even post-COVID, recently, a year or two ago. And then a recent increase in weight-bearing activities. Any answers for those?
Recent increase in weight-bearing activities. Subluxation, slipped femoral.
Lift upper femoral epiphysis. Yeah, that's a great one. I haven't talked about pediatrics, but that is a great one to have on the radar for a child aged between 11 to 16. That's the most common age for a SUFI, or slipped upper femoral epiphysis. And they will definitely not weight bear, and their leg will go into external rotation. And the other thing to be wary of with SUFIs in that age group, because our A&E and a few other A&Es have missed it, is that the child typically presents with knee pain only, because we know the hip pain can radiate to the knee. And the patient is presented with A&E not once, but twice. And it's only when the orthopedic registrar has been called and the hip has been imaged, because the knee x-rays were absolutely fine, that you find the SUFI. So stress fracture is the main thing.
Iliopsoas tendinopathy or tear.
Tendinopathy. So that again is unlikely to cause difficulty in. Oh, sorry. Recent increase in weight bearing can cause. I think that's more product of overuse for sure. So that's a good one too. Yeah. But the number one thing that would you need to think about that would require referral or imaging is a stress factor again.
Okay.
Great.
Yeah, quite a few people answered that. So
yeah, excellent. So everyone's on the right page. And in fact, I had a referral from a physio today from a lady that did do a marathon in early April, the Brighton Marathon rather than a London Marathon. And she has difficulty running. And although she has returned to running a 5K with mild pain, she saw the physio, and the physio said straight away, you need to see a specialist. So I think everyone's on the right radar, that diagnosis is on the radar, which is great. Okay, some other important questions. These are sort of more questions directly related to the character of the hip pain and any associated issues. So what would pain on prolonged sitting suggest? Now, there are two things that can cause two locations actually. You can get groin pain with prolonged sitting, and this particular pathology I'm thinking about can cause groin pain on prolonged sitting. And then the other pathology causes, and is pathognomonic almost, of pain in the buttock for sitting more than 30 to 40 minutes. So, answers for groin pain for prolonged sitting and buttock pain for prolonged sitting.
We've got quite a few. We've got OA, FAI, hip impingement, FAI, gluteal tendinopathy, proximal HS tendinopathy, coccydynia, piriformis syndrome, trochanterbursitis, ischial bursitis, which I think I have.
You haven't come to see me yet then.
I'm getting really worried by this presentation. Nerve root compression, deep gluteal syndrome.
Yeah, perfect. That's really good. So the number one diagnosis, particularly now you're getting to know me and I'm a young adult hip specialist, is FAI with usually labral tears. So when you're sitting down, the anterior labrum is getting irritated. And I'll never forget this one patient I saw who presented to me with difficulty sitting down for a period of time, groin pain. And he's like, Doc, you need to do something. I've just bought unlimited Odeon tickets and I can't sit in the cinema for more than an hour. That was his presenting complaint because he paid, I think, £20 for unlimited Odeon cinema vouchers. So that's groin pain. And it's labral irritation, really. Buttock pain is typically deep gluteal space syndrome or piriformis syndrome, which encompasses a number of conditions. And the number one is hamstring tendinopathy, because that sits on the ischial tuberosity. Can also be ischial bursitis, but it's sometimes hamstring tendinopathy, and that responds really well to a steroid injection. Well, they both do. So that was good. Well done, guys. Oh, okay. Childhood issues of any history of childhood problems. The number one is if they play a lot of sports in their childhood and adolescence, and we're talking pivoting sports in particular, like tennis, football, and also golf, actually, particularly with the leading leg, the left leg, then that is a risk factor for developing FAI or femoral acetabular impingement or hip impingement. And then obviously, if they have had childhood problems with hips, with clicky hips, that might be a sign of dysplasia, which I didn't put down. Steroids and excess alcohol, AVN is the number one. Steroids and excess alcohol together account for 80% of cases of AVN or avascular necrosis. And I was very quick on the buzzer, so I won't click on this time. But what's the causes of pain in other joints with or without constitutional symptoms? What are you thinking here?
Just coming in, everyone answer the last one. Couple of teachers' pets there. Nathalie and Sarah got that one right. RA, we've got rheumatoid arthritis.
Perfect. Yeah, it's it's any inflammatory condition.
Spondylitis, yeah, autoimmune arthritis.
Perfect. Yeah, so exactly right. Rheumatoid arthritis typically is multiple joints. It's a polyarthropathy. They can get constitutional symptoms. The other very common one I see, mainly because I'm at Royal Free and we have a big dermatology unit, is psoriatic arthropathy. But also don't forget angstbond, which can cause sacroiliitis as well as spinal pain. So imaging of the hip. X-rays are very quick and easy to do and actually can give me a lot of information. These are the X-rays I like to do. So if I think a patient has arthritis, I asked for a low-centered AP pelvis so I can see some of the proximal femora. I always ask for calibration sphere because I use software which allows me to calibrate with the degree of magnification and plan my hip surgery. If there are a young adult hip problem, and young adults, you'll be pleased to know, is anywhere from 15 to 55 in my NHS practice and privately. So I'm still a young adult. What they need is a standing, low-centered AP pelvis with the patella pointing forwards. What that allows me to do is appreciate the femoral neck geometry better, and it's a standardized way of assessing it. I also asked for a modified done view, which is a special view, which looks at the profile, the anterior profile of the femoral neck at 45 and 90 degrees, which is, again, a really useful tool, and I'll show what that looks like. But the MRI is a gold standard for imaging the hip. It gives us great information about the labrum. It can quantify the amount of femoral acetabular impingement, particularly CAM lesions. And there's now much debate about whether an arthrogram is needed. We have 3T scanners, and there are a number of 3T scanners affiliated with scan.com. The one I like to use is MedNeo, which is absolutely stunning images. And because of that, I'm doing far less MR arthrograms to determine if there's a labral tear, which is obviously a lot of benefits to the patient because they don't have the discomfort of having a needle being jabbed into their hip joint. I occasionally do CT scans, particularly if they have an asymmetrical rotational profile. So, for example, if they can internally rotate to just only 0 and externally rotate to 45 degrees, that suggests there's a rotational morphological problem of the proximal femur, and that helps me plan surgery too. So I'm going to give you a really nice case here I did about 9 months ago, and it illustrates why sometimes when you refer a patient for an X-ray, or if patients present with groin pain, it just warrants further investigation, probably with an MRI scan. So I saw this 30-year-old male solicitor who was referred by a sports doctor who eventually saw him after he went around the garden to try to find a diagnosis. He had about a year history of groin pain. And I think his GP thought it was a hernia, so it's investigated extensively for a hernia. An ultrasound found like a very small hernia, but that wasn't really the cause of his symptoms. He was an avid hockey player, which involves a lot of pivoting on that hip. He also played golf. And interestingly, his pain radiated down the thigh from the groin to the knee. So then they thought it was sciatica. So then he had an MRI scan of his lumbar spine, which was negative. Eventually, the sports doctor got an MRI scan. Well, first of all, sent it to me because he thought his hip movements were irritable. And what was interesting is that he stopped playing sports for 6 months and his pain got better, but he was super keen to return to sports. That was his way of dealing with mental health, etc. Past medical history was unremarkable, and the examination confirmed a quite irritable hip. And the main maneuver I look at here is flexion in neutral alignment. And usually they can flex to 90 okay, but anything beyond 90 causes groin pain. And internal rotation, and then also flexion, adduction, and internal rotation, or the Fadir test, can then irritate the labrum or can be a sign of hip impingement. So this was initially the X-ray, which was reported as normal. And to my trained eye, I thought there was something going on here, and potentially something going on here. So I ordered the modified done view, and what you can see here is a couple of cysts, and these are called impingement cysts. And then you have here slightly convexity of the femoral neck. So this is all a large CAM lesion. We got an MRI scan, And this is an MRI scan of both his hips. This is the right and this is the left, which is the more symptomatic one. So if you look at the right here first, you can see that the socket is kind of over covering the femoral head, and he's got a little, well, a decent sized cam type impingement here. And what's happened here, because this has been going on for about 2 years now, by the time I eventually saw him, he's got these little cysts in the acetabulum. And the reason why those are there is because do you see this gap here, which is white and not the same gray? That's a focal cartilage defect in the socket with repeated impingement. And he's got a torn labrum too. So, what would you do next?
Wait for it. Physio, lol. Thanks, Jonathan.
What was the one after physio, Lizzie?
Has he tried physio before?
Yeah. So he's had physio. He's had physio. He's had.
Refer to you, basically. Arthroscopy.
Excellent. Is the correct answer.
Well
The thing though is that we know that hip arthroscopy, in the presence of such cartilage damage, is unpredictable. There are certain techniques we can do whilst we do the hip arthroscopy, but we know that patients that have cartilage damage that require microfracture tend to do not as well as hip as those that don't. Obviously, because there's been progression of damage. However, there is a fairly new technique, and it's something I'm quite excited about. It's a single stage cartilage regeneration technique that's been used quite prolifically in the knee, but the hip is quite rare. So I went to visit a surgeon in Germany who does them, and I thought this chap would be ideal for it. So those are the cysts that we talked about. So these are the arthroscopic pictures. What you can see here, this is the anterior superior labrum, and it's very red and inflamed from the repeated impingement. This is the ball, this is the socket, this is the labrum. And as we move further this way, so we come to here, you can see the labrum is pretty badly torn there. Doesn't look the same like here. And then this image is quite extraordinary. Quite a large pincer, so extra bone in the socket that's causing impingement too. So with a high-speed burr, if you compare that to that, I remove that, and then the labrum is there. I was able to pin that back. So these are the sutures to repair the labrum, still looking red and inflamed. But the real interesting thing was this. So this, once I pinned the labrum back to where it should be, you can see this mass, well, it wasn't massive, it's about 2 centimeters, and this is a depth of about 0.6 centimeters defect of cartilage. And what's important here is that although this is the defect, once you debride unstable cartilage here, the defect becomes bigger. And it's important to do that step, otherwise this will progress. And then this is the cartilage regeneration that I talked about. We take cartilage from a non-weight bearing area, and this is called minced or particulate cartilage, which we mix with the patient's PRP, which stands for platelet-rich plasma, and seal it with a fibrin glue. I'm very happy to say that about 8 months down the line, he's doing really well. Okay, let's talk about the knee. Let's answer the first question. Is the pain preventing sleep at night? What conditions in the knee might cause that?
We've got tear, cancer, tear. Oh, sorry, that jumped back up again. Hang on.
Tear. What kind of tear?
Kind of tear, Mike. It's not Michael. Salmon. Sepsis, tumor, severe OA, infection,
Yeah, you got it right. So tumor,
meniscal tear.
yeah. The mnemonic I remember is TIT, and so that's trauma, infection, tumor for anything serious or pain at night. Um, Unable to weight bear, and this is without a history of trauma.
Cancer, fracture, sepsis, arthritis, gout.
So the number one thing you need to worry about is septic
Loose body.
arthritis.
Yeah.
And remember, just that always needs to be on in the back of your mind, because that's the one thing. If that's the one of two conditions that I need to get out of bed for when I'm on call, unfortunately, I don't see it that often, because passing the joint for more than 6 hours just destroys cartilage, and that patient is almost doomed to have arthritis in the future. And then obviously treating arthritis in the future from septic arthritis previously is very difficult. Who knows what SONK is? SONK.
Nope.
No answers? Okay.
Hang on, gives osteonecrosis.
Yeah, exactly. It's spontaneous osteonecrosis of the knee, kind of analogous to AVN of the hip, but it doesn't seem to have the same risk factors. So it's not really dependent upon steroid or alcohol excess. It's mainly idiopathic. And SONK is now being superseded by this term, sorry for the spelling error, insufficiency fractures. So it's not really truly a fracture. If you were to do a surgical dissection of the medial femoral condyle, for example, you wouldn't see a fracture line. But at a microscopic level, that's what's happening. There's a disruption in integrity of the bone, and patients end up having real difficulty weight bearing. So this, if the patient's unable to weight bear and there's been no trauma, and you've excluded septic arthritis clinically, this is a condition to be wary of. And I know it's not readily appreciated. Um, and the reason why it's important to establish a diagnosis quickly is that, firstly, X-rays are going to be normal, and you can only diagnose it on an MRI scan, and the condition can progress. And it doesn't progress by a true fracture. What it progresses to is an area of complete cell bony death with collapse of the articular surface. So that's why it's important to offload the patient with crutches and protect their weight bearing for a period of usually 6 weeks. So that's why it's important to establish that diagnosis quickly, and refer for a scan or to a specialist straight away. Okay, history of trauma. Someone said fracture already, but the other thing to be wary of is extensor mechanism injury. So either a tear of the patella tendon or the quadriceps tendon. The reason why that's important is that sometimes patients will go to A&E with a knee injury, and the assessment will be done not thoroughly, and the A&E practitioner will say the patient is able to straight leg raise, but they're not actually straight leg raising. They're raising their whole leg using their hip flexors, but the knees bent by 20 to 30 degrees. And they said, well, actually, they're able to straight leg raise with a flexion deformity. And actually, that might be that might be an extensor mechanism problem. And I've had a couple of patients come to me, maybe 2 weeks, 3 weeks post injury privately. They paid to see me because A&E got it wrong. So please bear that in mind. Palpate along the extensor mechanism and make sure they can straight leg raise with the knee completely straight. Ligament injury is obviously always going to be in the back of the mind, and one to consider is ACL. Typically, an ACL injury will lead to patients describing a popping sensation and the knee swelling up almost straight away or immediately within 24 hours. Obviously, you can get other ligaments injured. The four ligaments in the knee, the main ones are the collaterals, so the medial and lateral collaterals, and they'll have corresponding tenderness in those regions. Posterior cruciate ligament or PCL, and then the ACL. Okay, large, rapid swelling or a hot knee. What are your differentials here?
Oh gosh, everyone's going nuts on this one. Fracture or soft tendon tears, tendon or ligament ruptures, grade 3 ligament and meniscus tears, arthritis, gout, septic arthritis, infection, gout, OA, RA, rheumatoid arthritis.
Excellent. You all got it right. So basically, as I mentioned, and you've got it now, septic arthritis has to be in the back of your mind. Inflammatory arthritis is an important differential, particularly if they haven't got fevers. And then remember to ask if there are blood thinners. I've seen a couple of patients with INRs of 4 and the hemarthrosis from fairly trivial injuries. And the knee can rapidly swell up, as I mentioned, following a multi-ligament injury or particularly an ACL tear too, which I didn't mention. Okay, mechanical locking, easy one.
Bucket handle tear. Someone was on the keys for that.
I know. Excellent.
Meniscus tear.
Yep. So the meniscal tears will cause some pain and localized pain to that area, so medial or lateral. But it's the bucket handle tear where the meniscus gets stuck in between the joint that prevents full extension. Is the main cause of the locking. Okay, one other important cause of locking in the knee, particularly.
Let's have a look. Loose body.
Perfect. Can everyone see that? Can everyone hear that? This was a patient's consent.
We didn't hear that.
Did you hear that? Can you see this? I can't see if you can see this. Oh.
I can't see. I can only see the slides.
Oh yeah, that's right. You can't see that.
Can anyone else see it?
Am I not on the video?
They can see, but not here. Yeah, people can see it, but not here.
Anyway, the reason why I'm saying this is because this I fished out 2 loose bodies from a patient's knee today, just before this webinar, and he basically is a 63-year-old guy who had intermittent locking and persistent pain for about a couple of years, and eventually saw me privately because he was just fed up. He's known to have arthritis, and he's known to have a previous meniscectomy, but he describes this very typical symptom of a sudden jarring and the knee giving way with acute pain. And everyone thought it was down to his patellofemoral arthritis. And it's only eventually when he had an MRI scan that we were able to diagnose a problem. The loose body. Okay, other knee questions. If they've had previous trauma with ongoing symptoms and they've had no previous imaging, what are you concerned about?
Just waiting. Unhealed fractures or AVM?
Osteochondral injuries is more, if it was a fracture, they would present somehow, I would imagine. There are very few cases of neglected bony injuries, but osteochondral injuries, where a fragment of cartilage and bone comes off and floats around the knee, can potentially cause a loose body as well, is something to be wary of, and a progression of a degenerative meniscal tear. I'll go through these quickly because we've got some further case presentations. So recent increase in sporting activity or impacts. Again, stress fracture, overload injury of various tendons. So the runner's knees, for example, causes iliotibial band frictional syndrome. Tendon problems. I see a lot of people with patella tendinopathy when they're playing basketball or jumping sports, for example. With calf swelling, you've got to be wary, or it must exclude a DVT, but the differential is also a ruptured Baker's cyst. So when I see a lot of young patients with sports-related knee problems or increased activity-related knee problems, I use this, which is available from my website. It's called the Modified Cincinnati Score. And you have these main subheadings, and they get a score. The total score is out of 100. It's typically used, I've used this when I was writing my MD thesis for cartilage repair. And so we determine the score before and then 6 months and a year afterwards to see how much improvement has occurred. But it's a useful framework which I use. And I'll use this to talk about my case discussion here. So when it comes to knee imaging, again, weight-bearing x-rays should always be the standard. And if you have access to referring patients for x-rays, please ask for weight-bearing x-rays, unless there's been a recent trauma and they can't weight bear and you're suspecting a fracture. The reason why the weight-bearing is important is that the joint space gets significantly narrowed, but it may when they're weight-bearing as opposed to when they're lying down. And then it also gives me an idea of their alignment, which is super important if you're considering any surgery. Once again, MRI is the gold standard because it gives us valuable information about all of these structures inside the knee. And occasionally I do CT scans for complex bony cases. In all cases of a revision surgery, they need a CT scan to assess the tunnel positions and whether there's been any osteolysis and widening of the tunnels as a result. And obviously for fracture healing. So this is a really interesting case. A 30-year-old male, a chef who I saw in March. He was living in Australia and he had a footballing injury about a year before. And at the time, he told me the MRI only showed up an MCL. Obviously, I didn't have access to that. His knee was okay, but was never quite right. He did lots of running and he sustained a twisting ankle injury as well as an injury to the knee, which then led to intermittent swelling, stiffness, and giving way. So if you go back to that, his modified Cincinnati score was 57. It's pretty low for a young, fit, active person. And these were his MRI scans. His x-rays were unremarkable. This is the patella, and you can see he's got a big osteophyte there, and he's got a big osteochondral defect there. So part of the bone and the cartilage has come off. He's got a couple of loose bodies here in the lateral gutter of the knee. This is the coronal views, and you can see here cartilage is lining nicely this compartment. It's nice and gray, but here there's a full thickness defect. There's a little tear in the meniscus here. This is a side view, again, with a big loose body or osteochondral defect here. So his knee was not good. We made the decision to perform an arthroscopy, and I warned him that there's so much going on. I really do not know if I can make your knee better or how better by simply just removing the loose bodies. I had a strategy in mind. I was trying to repair the meniscus. And then again, so this is the MRI summary. And the intraoperative findings were quite significant. In the trochlea, there were 2 large osteochondral defects. There was a massive medial femoral condyle defect, a big lateral femoral condyle defect as well. So these are the loose bodies I took out. I had to convert to an open procedure to manage all of these osteochondral defects. So you can see this big defect in the medial femoral condyle. And then once again, I used AutoCART here as a single stage cartilage regeneration to fill that defect. This is the lateral side. Again, that was filled very nicely. And then this is the trochlear surface. And you see this here. This is a large osteophyte, a bony bit that should not be there. That was removed. And then I filled those defects with cartilage as well. And I'm really happy to say a year after surgery, after the long rehab, his modified Cincinnati score is now 84, and he's delighted with the results of surgery. This is another classic case of where an early MRI scan would have been really helpful for this patient. This is she's a 29-year-old female, really fit and active. She's been complaining of 2 years now of lateral knee pain. Kind of started about 6 months after she was doing some intense exercise classes called F45. Not entirely sure what that is, but on one particular day she was unable to walk the next day because of this exercise class, which involves a lot of jumping and pivoting. So she stopped her high impact work, and then she's just simply walking in hilly Hampstead, and this resulted in painful clicking, and she noticed a lateral swelling. Everything else was unremarkable in terms of a history. Examination revealed slight lateral swelling, but nothing significant. A tender lateral joint line and the Thessaly test was positive. And this was an MRI scan. So the one here on the left was initially, you can see this is the anterior horn of the lateral meniscus with a large horizontal tear, and a radial component here as well. And this is associated with a parameniscal cyst. So obviously, having counseled appropriately and determining that she wanted to return back to high impact activities, we agreed to do an arthroscopic meniscal repair, which I duly did. She was very happy with it. We had to scan the knee because she was getting some natural pain here. And so this is a post scan about 6 months later, where you can see that the meniscus is healing nicely. If you compare that to that, there's still some signal changes, but by and large, the meniscus is where it should be, and she was happy. So to summarize then, I hope at the end of this talk, you have a fair idea of when to refer for a scan and when to refer to a specialist. I think if patients are getting mechanical symptoms or instability following trauma, they should see a specialist straight away. And for physios, if they're having rehab and it's not getting them to where they need to be or want to be, it's very useful to get an orthopedic specialist review. We can quite often do injections to target injections to give them that pain-free window to rehab better. And I always tell patients it's not the injection that makes them better long-term, it's the rehab that you do. For hips, if they have persistent groin pain or lateral hip pain, particularly if they've done a marathon or increased activity, then that's worth getting an opinion. We're getting a scan, certainly. If they have ongoing pain, particularly 12 weeks after hip arthroscopy, and they have difficulty rehabbing, it's probably worth them seeing the surgeon again. And if they find that they've altered their gait pattern, I think that's a useful sign for them to see a specialist. By that, I mean they're not they're limping effectively, or they have some sort of protective mechanism. A few tips for the image referrals. It's always useful to have a mechanism duration of, remember the 3Ds basically, and ask a clear question if you can. It just really helps, particularly if you're sending for a scan without seeing a specialist. It'd be useful for the radiologist to know what's going on. The key takeaways, though, is that not every patient needs a scan, but hopefully you now know that a timely scan can help prevent further deterioration, and early referral prevents deterioration of the patient. Thank you very much. These are my details. I'm very happy to discuss cases and collaborate. I'm very happy for Lizzie to share the slides in PDF form as well for you guys.
Yeah, I can do that after the call. Thank you very much, Parag. That was fantastic. We've got like 115 people on the call who've all been really engaging, and I will share Oh, please tell us the procedure you learned in Germany. This is the last question, maybe, before we wrap.
Yeah, so that was the autocart, was a single stage cartilage regeneration technique that I showed you for the hip.
Nice. Thank you, Parag. Yeah, so his details are on the screen. I will share the slides, the PDF afterwards. If you want a certificate, please get in touch. Thank you so much, Parag. Have a wonderful evening, everybody. And
Thank you,
thank
everyone.
you for your engagement. Take care. Thank you.
Bye.
Bye.